Alaikum warahmatullahi wabarakatuh. American Association of Endodontists and the American Academy of Oral and Maxillofacial Radiology joint position statement, use of cone beam computed tomography in endodontics 2025 update. This statement updates the recommendation on CBCT use across all stages of endodontic treatment, incorporating evidence-based advancement since the 2015 statement. The statement provides guidance. Clinical judgment must be individualized for each patient, and the successfully outcome of endodontic treatment are mainly depend on accurate diagnosis and appropriate treatment planning. Imaging is essential in endodontic care, including diagnosis, treatment, obturation evaluation, and healing assessment. While two-dimensional radiography remains relevant, however, in such cases like complex anatomy may limit interpretation, and in this situation CBCT enables three-dimensional assessment. CBCT should not be used routinely or for screening, and should be considered only when lower dose of two-dimension imaging is insufficient. Because of the wide variability in CBCT systems, evidence-based scanning protocols are essential to achieve adequate diagnostic image quality at the lowest possible radiation dose, with protocol selection primarily based on field of view and voxel size, while considering exposure parameters according to the specific clinical goals. CBCT image quality may be compromised by inherent artifacts, including scatter, partial volume averaging, patient motion, and metal-related artifact. This can affect diagnosis. However, these can be minimized through appropriate voxel selection, and also region of interest positioning, scanner calibration, and post-processing artifact reduction algorithm. CBCT delivers a higher radiation dose than intraoperative radiograph, so current evidence support a shift toward dose optimizing rather than minimization, emphasizing individualized protocols based on patient factor and diagnostic needs, particularly in pediatric patients, while maintaining diagnostically acceptable image quality. Effective use of CBCT requires advanced training beyond conventional two-dimensional imaging. So the AAE and American Academy of Oral Maxillofacial Radiology encourage formal education, interdisciplinary collaboration, and consultation with the oral and maxillofacial radiologist when needed. For the recommendation, starting with the diagnosis and the preoperative treatment, CBCT should be preferred imaging modality for preoperative diagnosis when clinical symptoms or radiographic findings are non-specific, as it improves detection of periapical pathosis and may clarify etiology when two-dimension imaging is inconclusive. And also intraoperative radiograph like bite wing may complement CBCT when needed. For the intraoperative recommendation, limited field of view CBCT should be preferred for intraoperative treatment to identify and localize of calcified canals and management of iatrogenic errors. Since it's more accurate than the two-dimension radiography. Post-operative treatment, it's recommended while when the post-operative complications are suspected. Starting with non-surgical retreatment is recommended when examination and two-dimension radiograph are inconclusive for detecting vertical root fracture, recognizing that detection depends on fracture size, artifact, and image resolution. And also it's preferred for evaluating non-healing after previous endodontic treatment to determine the need for non-surgical retreatment, surgical intervention, or extraction. Also, it's recommended when there is to assess treatment complication such as overextended obturation material, separated instruments, and perforations. For the surgical retreatment, it's indicated and preferred for pre-surgical planning, allowing accurate localization of root apex and assessment of proximity to adjacent anatomical structures. Also for special condition like implant placement, and also it's recommended in traumatic injuries to localized dentoalveolar trauma, including root fracture, luxation, and displacement when no extensive maxillofacial injuries are present. Also, it's recommended for localization and differentiation of internal and external resolved defect to determine appropriate treatment and prognosis. Also, it's recommended in outcome assessment and intraoral radiograph. In absence of clinical signs or symptoms, intraoral radiograph should be preferred for evaluation of healing following non-surgical or surgical treatment. However, in asymptomatic cases, limited field of view may be appropriate for follow-up only if it was indicated or at initial evaluation. So in conclusion, CBCT has significantly influenced endodontic practice by improving diagnosis and treatment planning. This update incorporates evidence-based advancement since 2015 and emphasizes case-by-case appropriate CBCT use based on clinical need and radiation consideration. Thank you.